All right. We're now going to move to our fourth session, and we're going to take our full 45 minutes for this. I know we're about 2 minutes behind, but we'll take the full session. And this session is on the future of value-based care in the Medicare program. And you're going to hear from three speakers. You're going to hear from Jake Quinton out of HHS, Farzad Mostashari from Aledade, and we're going to ask him to tell us about Aledade, and then Mara McDermott from Accountable for Health. They bring three distinct perspectives on this important role. And I just want to jump right into it. Jake, with you, you're the CMO for Original Medicare, Medicare A and B. And I know that some of your issues have been touched upon by a few previous speakers, but I know that you've got some special insights that you're going to be able to share with us with regard to alternative payment designs. I know you're going to hope you make a strong point about choice and competition between Original Medicare and Medicare Advantage and some other key issues. So, Jake, without further ado, give us your best 8 minutes.
Thanks so much, Cliff, and really looking forward to the conversation. I listened into the tail end of the prior discussion with Dr. Susanna Bernheim from the Innovation Center, and in particular, I think a great lens by which to view this entire conversation is sort of bringing forward some of the great innovation that came from the Innovation Center into fee-for-service Medicare, thinking about how are we infusing the innovations that came from CMMI into the underlying payment calendars. And the specific example she was alluding to is when we had great evidence from our Million Hearts model, randomized design, actual demonstration of a mortality improvement based on appropriate ASCVD risk screening. And we were able to bring over the results, core elements of that model in what we call scaling into the physician fee schedule for these ASCVD codes. And so we now have an add-on service for evaluation management that incorporates the core elements of that model. And so as a very specific example of what we mean by scaling, not certification and expansion of CMI models, but how are we taking the lessons learned from CMI and bringing them over to the Center for Medicare. Just a quick bit about me. Spent 4 years at the Innovation Center working under Susanna's leadership and others, and now I have the opportunity to be the CMO for parts A and B for original Medicare, as we call it. And certainly even talk a little bit faster than Susanna, so we'll try to be comprehensive. As we think through the next 2 to 3 years and the steering of the $1.2 trillion Medicare program, we're really thinking about how we're encouraging choice and competition between the two halves of the house. So you could say parts A and B, original Medicare, Part C and D, Medicare Advantage. How are we rebalancing the scales, acknowledging and appreciating the rapid expansion of Medicare Advantage and saying there may be some needs for small tweaks, and you saw some of that come forward in the advance notice and the improvements for stars and some of the work on risk adjustment. And so you're seeing some small tweaks, but really the focus is going to be on our original Medicare parts A and B. How can we improve, strengthen, and accelerate the growth of specific. And when we think about that rebalancing, I just want to say one of the things that I think is most interesting, and certainly this sort of shows my bias, is trying to get to underlying empiric payment accuracy within the fee schedule. And you mentioned some potential need or pricing distortions. And when we think about where the information comes from to help us set prices as federal rate setters, we think a lot about sort of the groups that are surveyed by which and produce information for CMS by which we can help set prices. And certainly surveys have their inherent biases. It'd be so much more effective if we could find actual empiric data by which we could set physician fee schedule prices and others. So a great example of that was we took a look at the actual the surgeon's registry database, or NISQIP, where they place the actual time spent for specific cases by CPT, and we're able to say, oh, here's using underlying NISQIP data. Here's the actual time that was spent in the surgical case. Now let's cross-reference this to our estimates that are going forward in the fee schedule for that specific service. And we found that typically the fee schedule estimates were slightly inflated. And now that's not true for every service. However, on average, it typically was. That was part of our argument last year for what we called the introduction of a productivity factor, saying, over time, if you're surveyed as you develop a new surgical procedure or a new technique, you may actually become more efficient at it over time. And so, if there's an opportunity to incorporate that productivity factor adjustment or efficiency factor into our federal rate setting, that's a good thing for the American people. Now, I think we think a lot about how we're improving these fee schedules, not just physician services, but home health, IPPS, across all different sites of care. But really, focusing on the fee schedule, I think if you have one phrase to come back with, it's we want to achieve pricing accuracy. Now, we think that achievement of pricing accuracy is actually going to be a really good thing for accelerating the growth of our accountable care program. We at CMS think about accountable care broadly. We think about there's the accountable care program and shared savings, and that's our CMS's largest value-based care program for clinicians. We also think about our CMI models. They could be ACO REACH or LEAD, and these are really important demonstrations that Suzanne's team and others lead that help us understand how to continue to improve the overall Medicare program. But so we think on both sides of the house. Now, the house here being CM and CMI, these two programs we really want to focus on growing and particularly improving the savings rate coming through for our program. And if
Jake, when you talk about two things, sorry, you talk about pricing distortions before, fixing the fee schedule, pricing distortions and payment accuracy.
Yep.
So if you fix pricing distortions and get to payment accuracy, do you necessarily think this will get us to more appropriate care, high value care, diminishing low value care? What is it? I mean, it sounds like they're off base, but even if you fix it, are we in better shape? Will it incentivize better health care?
Well, I think this may be too much of a technician's perspective, but if we think about the I think in any universe we're thinking about sort of like who's it compared to, and so if we say this is how much Medicare is paying for a service, and over here in the commercial world we're paying 3x or 4x of that service, we should really like understand what our comparators are. Now, certainly, are you hearing me say that we want to the Trump 1.0 line, which was fee for service is the original sin in Medicare? We want to move everyone to Medicare Advantage. No, we're not saying that. We're actually saying original Medicare, particularly through expansion of the accountable care organizations and shared savings and LEAD, is delivering high quality care. Now, what I'm not saying is that we are happy with clinicians staying in unmanaged fee-for-service medicine. We're actually quite unhappy with that, and we think that we are delivering better value to the taxpayer and for our aunts and uncles and grandparents in the Medicare program if we have an expansion of accountable care adoption. So, original Medicare operates on a basis or a chassis of fee-for-service codes. Those are incredibly important, but we want to grow the important quality outcomes, the important improvements for beneficiaries that come from accountable care adoption. So we're saying that we want to rapidly expand both the shared savings program, the 20 ACO program, and we want the CMI models to do the same. So my answer to you is pricing accuracy is sort of getting our house in order, but we really want to expand our ACO program, and that's how we think they're going to be delivering high quality care for the American people.
Got it. Jake, I want to ask you for just a second. I want to come back in a few minutes to the competition issue and some of the kind of ramifications of the fee schedule. But I want to hand it to Farzad now because I want to make sure we get everyone in. And I'm going to circle back to you, Jake, on those two issues. Farzad, I didn't know much about your outfit until recently, but I kind of looked into what Aladeid's all about. I got to say, I was pretty impressed by kind of how you're sort of kind of using the latest in digital technology and some other aspects to make this work. But Farzad, let us know what Aladeid is it's and what its role is vis-a-vis CMMI and CMS.
Yeah, I think actually this was a great lead-in from Jake to me. He said, "How do we move people from unmanaged fee-for-service into accountable care organizations and structures, and that it's good for our aunts and our uncles and our parents." My mom was recently discharged from the hospital, and for the first time I can remember, we got a phone call from her primary care practice. And it was super helpful actually, because like all of our follow-up discharge planning was totally messed up. And I was so grateful. And I said, wow, this is a new thing. Like, when did you guys start this? And they said, oh, no, we've had this program, but your mom is now in an ACO. And I was like, why isn't everybody in an ACO? And I think that's the question that Jake is asking. Aledade is the largest enabler of independent practices joining the Medicare Shared Savings Program. We have 1.8 million of the 12.5 million or so lives in the Medicare Shared Savings Program that are supported by Aledade. We help them with the contracts, with the risk, making sure that there's enough lives for the practices to take risk, bringing them together, giving them the coaching, the regulatory help, uh, and the technology that Cliff mentioned to help them be successful. But we're not vendors, we're partners with them. We take, if there's a downside risk, we pay the downside risk. So we have skin in the game, and we split exactly 50-50, whatever the check from CMS is. And last October, during the government shutdown, we got a check or a bank deposit, it's a little less exciting, for $778 million, because we had created $1 billion of savings against benchmark for CMS. So I think I'm well situated to say, how do we increase, with the questions Jake posed, how do we increase participation in this program? We said 12 million, but there's like 28 million people to go get, right? And then how do we increase the savings, the performance of these? And I'm sure Jake and I can have a much longer conversation, and Mara, I'm sure, is gonna help round out my suggestions here. Um, but let me speak to a few things, and let me just say I love the framing that Jake used. That I haven't heard really the clarity of thinking from CMS. That it's not that we have this program over here, traditional Medicare, and this program over here, Medicare Advantage. The rate growth in MA is mathematically driven by the rate growth in traditional Medicare. And we hear public company MA CEOs, MA plan CEOs say that the rate notice wasn't good enough because it doesn't reflect the trends we are seeing. And I think Jake would say, I don't care what trends you're seeing, be better. You have to compete against traditional Medicare. So anything we do on reducing cost growth in traditional Medicare helps reduce cost growth across the entire book and has a more than one-to-one savings impact on the cost for the taxpayer.
That spillover effect is essential. I'm so glad you raised it. Thank you.
But the key question is, how do we reduce cost of care? And I think Jake is right that getting the underlying costs are important. We should not be overpaying for skin substitutes. Love it. But to your question, Cliff, what is the right price for a stroke that shouldn't have happened?
That shouldn't have happened.
Simply adjusting fee-for-service rates will not get us to where we need to go. We actually need to make it more profitable for somebody to prevent strokes than to treat strokes. And we still have the number one thing we could do to save lives, improve quality for the beneficiaries in Medicare. As important as all of the USPSTF requirements and screenings are, it's blood pressure control. And we are terrible at blood pressure control. And we at Aledade are at 84% in our traditional Medicare population, better than Mayo Clinic, better than Cleveland Clinic, better than Yale, where Jake and I were, better than Mass General, right?
You're better
Why?
because why? Yes, why?
Because we have the right incentives, right? because we get paid more and we have the patients for a decade, right, in their primary care practices. So it's P is important, but so is Q, right? And for us to say we need somebody here, and we think the one place where it's been proven is giving primary care accountability for total cost of care to drive down the things downstream of them, which includes acute care hospitalization. So maintaining and expanding and strengthening the incentives for primary care to care about reducing downstream suffering is at least as important, in my view, as the saving money part of this.
Farzad, so if I were a provider in your system,
Yes.
what would I say to my colleagues about what you're doing differently, how you're treating me differently, that is affecting how I manage my patients?
Here's what CMS has going for it in trying to move people to accountable care. Nobody doubts that it's the right thing to do.
Yeah.
The kinds of things we are asking people to do is what there's no objection. It's like everyone's in Starfield. Everyone's been saying, this is what good primary care is. You make room for your patients who are sick and haven't been seen in a while. You call them after they go to the emergency room or get discharged from the hospital. When they show up, you know what's going on with them. You are the quarterback of their care. It's just that fee-for-service is a really, shitty way to pay for those things. However much you want to pile on codes, it's not the right way to pay for it. The right way to pay for it, which we have seen, is giving them accountability and support for the total cost of care. Let me just quickly, because I know
Sure.
we're short on time. Let me just quickly tick off maybe some things that Mara and Jake can follow up on after I drop off. In terms of increasing adoption, one of the factors that CMS, if you're running a business like I am, right, after being a federal policymaker, if you're thinking about your customers, you have to think about how do you gain new customers and not lose your existing customers, your churn. And I'm not aware of anyone at CMS who is tracking what practices leave MSSP and going and talking to them and saying, why did you leave MSSP? And if you do that, you will hear some of the reasons that I hear every day. One of them was, if you joined in 2024, you are whacked with this accountable care prospective trend, which is just wrong. And it puts any practice who joined that ACO in an impossible position.
You're benchmarked incorrectly. We've heard about that earlier today, right?
Right. They are going to drop out of the program. It makes economic sense for them to drop out of the program. So too the 2025 cohort. So we are creating this uncertainty. My words to Jake's ears, they will solve this for 2025, right? But if they don't, they should not then be surprised that a whole lot of practices fall out of the program. A self-enforced error at a time when we're trying to increase participation. What's another reason why practices leave the ACO is one of them said to me, I don't want to send all my patient data to CMS for reasons that I think are understandable now. And the CMS quality requirements basically make it very, very hard if you're not in the ECQM track coming up. So they should rethink, I think, this like, why are we making it more difficult for practices in ACOs than practices who are staying out in MIPS, right, to navigate the quality world? And third, it's around cash flow. You do a lot of work and you don't get any payment the first year, which means it's 3 years before you make savings. The cash flow interval is just too long. Why are small primary care practices giving CMS an interest-free loan for 3 years, right? CMS, the one program or one of the few programs that was in CMMI that got certified by the actuary to save money was advance payments to practices, and CMS is not expanding that. There's a prepaid savings program that the previous administration put in place, and they had so many bells and whistles. I told you, we got $778 million in payments. We tried to apply for advance payments. We could find $10 million, and we got approved for $0 million. Zero. Okay. So it is. So these are the kinds of I apologize to Jake for putting it on him, but you are our hope that you can fix this. The self-enforced errors that we do here, and then I'll do one more, and then I'll jump off. I promise. The best ACO in the country was our Louisiana Enhanced ACO. They are amazing doctors. They were ranked, we have 80 Million Hearts champions, and they dominate those listings, the best practice in the country on blood pressure control. They rank the highest in all 476 ACOs on patient communication, on patient coordination, on access to specialists, and they had 17% savings rates in 2024. And they were rebased to 5%. All of the infrastructure they have had to build to support that 17% savings rate cannot be paid for at 5% savings rate.
No incentive to stay in the program.
So if you
get nailed
want
like that.
Louisiana doctors, and we're going to bring Dr. Menard up to meet with folks at CMS, if you want them to continue to be able to invest in the life-saving practice transformation they have done, we cannot have the long-term cap of 5% cap on total savings rate. You will get what you pay for on those savings caps. So I'm going to leave it there. And many thanks to
Thank you,
all for
Farzad.
hosting.
Thanks. And we really appreciate how you've given such pointed examples of where the past programs haven't worked very well, some disincentives, but it sounds like Jake's working on stuff to fix that. Before we go to Mara, Jake, do you have just a quick rebound take on anything Farzad just said, another minute or two, and then we'll go over to Mara?
Oh, this is great, and really glad to catch Farzad in and how we can, and certainly the Alidate's in conversation, as are many of our shared savings participants with CMS throughout these programs. I think the compelling stories he's telling about improvements in hypertension control, the compelling stories about how they're making care better for patients, I think are particularly well taken, and the issues he's flagging, be they APCT, be they the specific quality burden reductions, be they sort of these questions about rebasing and how to resolve it, are all known issues that our teams are working really hard to address. The specifics, wins and hows, some of it's up to us, some of it's fixed in the statute, but I think you're hearing a full throated commitment from CMS to improve our accountable care programs and wanting to leave no stone unturned. So I think lots to say, Cliff, and certainly don't want to steal too much time from Mara. We're looking forward to the conversation. But these are elements, known structural issues that are stumbling blocks on the way to accountable care adoption. And we're thinking about both for when we're thinking about adoption, it's going to be and the importance for expanding our ACO adoption across original Medicare. We're thinking not just we want to bring more people in, and we certainly do. The number, as far as that's flagging in terms of the potentially includable beneficiaries, who and why and how, I think are close to the mark. But then it's also thinking about what are the additional savings that we're getting. We know that there's been some, but limited savings in the overall program currently. And with the amount of investment and the importance of the program for CMS, I think it's just it's part bringing everybody in and then also increasing savings overall.
Point well taken. Thank you. Well, you stole zero time from Mara because Mara gets her full time, believe me. Because Mara, speaking about accountability, do tell us about who and what are accountable for health, your organization. And then we're hoping you'll hit on a couple, three topics. I know that fraud and abuse is a big one in your basket. Maybe one of the CMMI models, I think LEAD might be the one. And then we really care about if you could help us look forward with regard to the future of payment reform from the congressional side. I know Congress is kind of messy these days, I know, but if you could give us a little telescoping into the horizon, we'd very much appreciate that. But please first tell us more about Accountable for Health.
Sure, I'm happy to, and thanks for having me. I am also happy to share my time with Dr. Jake Quinton, so he should jump in at any point. Accountable for Health is a nonpartisan advocacy and policy organization. We're based in DC. We are made up of a broad spectrum of participants in the accountable care ecosystem. So ACOs like Alidate, Farzad's company, is a member of ours. We have consumer advocacy organizations like American Heart Association, as an example. Specialty care. So I know we're not spending a ton of time on specialty value-based care, but Accountable for Health spends a lot of time, particularly on kidney and oncology models. And we were formed about 3 years ago around when the direct contracting model, which was a predecessor to lead and reach, like sort of turn the page back. There were a lot of political questions about that model and the transition from the first Trump administration to the Biden administration. And it showed sort of a weakness of understanding about what accountable care is and its goals and where we want to go. And so Accountable for Health was formed to really fill in those gaps and provide an education and policy voice around the need for accountable care. I love the place where I think Jake started, which is, sort of a recognition that accountable care really is working in traditional Medicare and original Medicare. Sorry, I'm going to have to flip my brain on that. Original Medicare, and should be a vehicle for the future to be competitive with Medicare Advantage. We've thought that for a long time. So I love the validation of that. I wanted to maybe start on the fraud and abuse topic, which relates to ACO savings and the earlier conversation. I think one of the things that ACOs have now proven they are amazing at is finding abnormal patterns in healthcare data. And in the specific case of skin substitutes, ACOs, I think, although Jake can correct me if this is incorrect, the ACOs were the first to sort of like, besides maybe CMS, the first to raise their hands and say, we have a problem here with skin substitutes. And the specific problem relates to the way that those products were paid for, which is by the square centimeter. A huge range from roughly $11 per square centimeter to $5,770 per square centimeter prior to some new payment rules coming out of CMS. Yeah. The overall total, I think CMS's estimate is around $15 billion on skin substitutes for 2025. Our less official estimate is around 17 billion, just because we've seen a massive increase in billing at the end of 2025 that I think is not accounted for in the early part of the data. CMS, as I mentioned, I think largely because of the support of ACOs who were able to show data, evidence, point to specific providers, issued a payment rule to cap all skin substitute spending at $127 per square centimeter starting in January 2026. So while as we sit here today, the skin substitute manufacturers are suing over that rule. We hope the government prevails, obviously, but it continues to be an active area. The Congressional Budget Office just did, in its new report, estimate that the savings resulting from that policy change in the physician fee schedule is $245 billion over 10 years. So a massive amount of waste in the system. And as we think back to, Dr. Burnham was talking about WISER and the need for some test of prior authorization in traditional Medicare, skin substitutes to me are the shining example of why more oversight is needed, why more management is needed, and why you need somebody looking out for the beneficiaries in traditional Medicare. So I tout that as a real success story for ACOs. I will just get on my little soapbox and say, I don't think that any of that savings, like putting your hand up and saying, oh, there's $245 billion of fraud here, and we are going to help you, CMS, root it out and stop it. I don't think any ACO evaluation on the planet counts those savings in the ACO wins column. So as we think about the longevity for ACOs, I think we need different mechanisms for giving them credit for all the good work that they're doing.
So Mara, just before you leave that point,
Yeah.
No one likes fraud and abuse.
Right.
It's a very popular thing among members of Congress and so forth. Why shouldn't ACOs tout their ability to detect, let's say, abnormalities in the data that could then lead to detecting fraud and abuse? And by the way, we save more money when we do that. To me, that would be kind of a pretty good selling point. But I don't remember ACOs being linked to fraud and abuse, at least not in my mind.
Yeah, it's interesting. My perspective on it would be good to get Farzad's perspective on it. It's too bad he's gone. But I think that the data capabilities ACOs have dramatically improved. And that's why we see it now and we didn't before. And this is not like new this year. There was a catheter fraud problem a few years ago. And I think ACOs, again, were on the forefront of that. But I would say over the last 5, 6 years, 4 or 5 years, something like that, the ACO's abilities to consume data, to translate data, to feed things back to the government have skyrocketed, like just dramatically improved. And that is allowing them to fulfill the promise that was always there to participate in waste reduction and fraud reduction across the Medicare program.
Jake, does that ring a bell to you?
In that we think the ACOs are incredibly important bellwethers and actively engaged participants in reducing fraud, waste, and abuse. Of course, of course. And I think that Mara's flagging some really important points. So certainly, the aberrant behavior that is associated with skin subs, we expect and continue to work every day to ensure that there was a one-off, rapidly growing and remarkably expensive event, and to take steps to make sure that it doesn't happen again. And broadly speaking, as we build towards the future across our ACO programs, thinking about how what are those data feeds that are helpful right now? Is it an ADT feed? Is it something in Reach called BCDA? I'm going to stop throwing acronyms, I promise, or do it like a wiser approach to sharing additional information that's going to be helpful for ACOs to coordinate care. And I think Mara's characterization of like ACOs being some of the first to flag these issues is entirely correct. And so I think this is one quite high profile, but a really great example for the important roles ACOs have in reducing fraud, waste, and abuse in original Medicare. I don't think it's the only reason that ACOs are incredibly important to us. I think Farzad's highlight of particularly like the hypertension control in the Aledade ACOs is a great example as well. But I think as we go forward, Cliff, I just want to say, and I don't want to forget about the fact that we spent a lot of focus on the shared savings program. That's within my shop, and certainly like his core to many of these questions. We know that there's been great successes in the CMI demonstration model, ACO Reach. There's much to be said there, particularly for focusing on high cost beneficiaries. Really interesting explorations in terms of how they're paying for primary care in different ways. And I think, and we're all kind of waiting on bated breath for specific information about ACO lead to drop like towards we expect sort of later this month. And so there's the evolution of the ACO models that's kind of happening before our eyes. And so there's going to be some really exciting opportunities, certainly along those lines as previously, and then excited to see the next version of these ACO models come out for ACO lead. So just to reemphasize the point, CMS believes we want you to join one of these programs, either shared savings or lead, and we don't differentiate between the two of them, and actively are in conversation on things like skin subs, other areas of fraud, waste, and abuse, and working together in partnership with CMMI.
Great stuff in the pipeline. And the skin substitute thing, gosh, really caught my attention, I must say. Mara, back to you. There are a couple more issues we hope that you'll hit on.
Yeah, I would just pick up on what Jake was saying about LEAD. Our members are very excited about LEAD. Obviously, we're waiting for financial methodology, and I'm sure they'll have feedback, as Jake knows they always do, on what like the details. But I would say in terms of what we've seen so far, a new 10-year model out of the CMS Innovation Center for this sort of other flavor of ACO, right? We used to do the ice cream cone, like MSSP's vanilla, and LEAD will be chocolate. And so like both ice cream, both great, but different flavors. We are very excited about that. We see a lot of really interesting tea leaves around managing complex populations. So I think with the high needs ACO Reach program that will be wrapping up at the end of 2026, we've seen a ton of success managing patients with, I think on average, the most recent evaluation says 12 or more chronic conditions. Patients who are homebound, patients who are very frail. We just see a lot of the infrastructure built into the LEAD model that I think is going to enable those companies that are focused on that population to be very successful, and also invite in ACOs who had maybe not focused on that population to bring those beneficiaries into their ACOs through some creative risk adjustment strategies, attribution strategies, and other things. So we are very excited about LEAD and agree completely that we want folks in models, and that can be Reach, that can be LEAD, that can be CKCC, but continuing to press forward on accountable care. And the last thing I would say, which we haven't touched on yet, is a real focus around bringing accountable care to rural areas. And we see that reflected in LEAD as well. And I know that many of our members are hopeful that they'll be able to pair some of the state-based strategies through the Rural Health Transformation Program and LEAD to expand coordinated care in rural areas where there maybe hasn't been as much of it in the past.
Mara, I want to reflect on a question or two that we've gotten. I'm just
Yeah.
paraphrasing here. Um, with regard to the highest opportunity patient groups and or outcomes. You mentioned the complex patients. Are they the highest opportunity set of patients to pursue in a program like LEAD? In other words, is there a lot of potential yield there for not only outcomes, but for savings in those complex patients, the multi-morbid patients and so forth?
I think it's really going to depend on the ACO. I think we
Mm.
certainly have ACO. I mean, we'll see because we don't have financial methodology yet either. So my members would kick me under the table for saying anything too strong. But I do think that that appears to be an area where the Innovation Center is particularly focused, just, reading what we have to date on LEAD. I think that it's not just that though. It's not just the complex populations. I think we see a real leaning into rural and a real interest in bringing, as Jake said, bringing new organizations to the table. So I wouldn't be sitting in your audience thinking like, well, I don't have a frail homebound population, so maybe LEAD's not for me. I think there is something in LEAD for a broad swath of participants. There's something in MSSP for a broad swath of participants. And I would be viewing it through those lenses. Jake, you may want to add to that.
I
Yeah,
think
Jake.
I think it's well said. All I would say to add is that if if you're finding yourself that you don't have a home in one of our ACO programs, be it shared savings, LEAD, what have you, we want to know about that. And that's important that there is a place for a small rural, like 2 or 3 clinician practice, a large system, a like a particularly like home care focused organization. And I think all we want to be able to incorporate all players. There's and a lot of consideration. Mara's brought up kidney a couple of times. Those peculiar conditions for which there's kind of a principal owner within a specialist, be they kidney care, be they oncology. Trying to think through sort of how we're bringing those additional players to the fold over time. But I think that the principles are the same, and so if you're in the audience saying, that like shared savings doesn't work and here's why, one of the things Farzad said that I most agree with is, we should be talking to those that have left shared savings and try to understand why they left and how we can what program modifications we need to make to encourage them to come back. Certainly, Cliff, we've been tightly focused on original Medicare. We know that the future value-based care is competition between the programs, but a lot of what we're describing here is how we think the programs will be evolving over the next few years.
So in listening to the two of you, Farzad before and others, it seems like there's an emerging menu of models out there. And how might I, whether I'm a small rural practice or big urban kind of huge practice, how do I kind of navigate the menu? You just persuaded us that it's not like lead is for this group and access is for somebody else and reach is for something else and shared savings for somebody else. It sounds like you're laying these models out as being relevant to a wide swath of practices. Is that correct? And if so, how do I navigate that?
Mara, I'd love
Well,
to hear
Jake,
I'd love to hear your comments on this as well. It's like being, and actually, your closing speaker with like Michael Chern, who's written on this at the start of the last administration, saying the Innovation Center previously let 1,000 flowers bloom. Can we move toward a consolidated portfolio of opportunities? And I think that a lot of this comes through in how CMS considers risk. Is every single organization that delivers care moving to downside risk? Maybe, maybe not. Do we think there should be an accountable entity for every Medicare patient? Absolutely. And how and what level of risk is something that we think that there's more of a market orientation in this administration towards solving for. And I understand, Cliff, that I didn't answer your question of the exact flavor and spectrum, be it two different kinds of ice cream or otherwise, for which we're seeing folks slot in. So, but to be more specific, we have the shared savings program that moves forward and continues to make improvements on a calendar year rulemaking cycle. We have the LEAD model as another flavor for large population-wide accountable care organizations. For entities specifically focused on kidney care, we have the Kidney Care Choices model and the ESRD ACO, and so there's an opportunity there for that population. We have our oncology care model, or enhancing oncology model now for the Innovation Center. And you saw kind of underappreciated in all this work, a really important update or tweak to the MIPS program, or building out the chassis of the MIPS program, our ambulatory specialty model. And so there are a number of offerings trying to say that broad population-wide accountability, narrower populations may need some more tailored programming, and then there are some episodes of care for which we think we can accurately price. In the mix, you'll see, and this is not to make things more complicated, but we're looking to provide additional information and options. We had some good success with what we called shadow bundles last round, and then now there's more opportunity to give information to ACOs to help them design their own episodes. But this conversation's been evolving for a long time. Broadly, what we think, we need to make it simpler. Absolutely. We need to make it comprehensible. I see patients 1 day a week. Having these conversations with patients is challenging about which ACO they're in and how this makes sense. What we really want it to be is for any single practice that comes, any single patient that comes into the practice, that any single clinician knows what an ACO is. How can they understand that they're part of it? And we need to maybe deburden patients from the administrative speak that we speak so well at CMS. And so when we're thinking about these options, we really just want to make sure that there's clinicians that are accountable for patients, and we want to make sure that those are true across the board in the setting that makes the most sense for them.
Got it. So thank you for that. So Mira, given your diverse constituency, how do you portray the outlook for these models to them as opportunities to provide more accountable care? Again, to me, it's like a lot of models out there, a lot of moving parts. Where do I sign up? And particularly if I've been dissatisfied with certain aspects of, well, MIPS or shared savings, what have you.
Yeah. I mean, I have a couple answers to that. I think one thing is we try to support our members and give them the tools to make good decisions about models that will work for them. That includes partnering with actuarial firms once we have the details we need to make those decisions. I think the other thing is that the models are designed in a way where it may feel like there's 50 entry points, but I think for every organization, really there's one or two. And so that decision isn't as broad as it seems. The other thing that I sort of have to say on behalf of Accountable for Health is we're an advocacy organization, right? So we are not necessarily just waiting for CMS to tell us what the LEAD model is. We've been in there talking to them about what we want the LEAD model to be since Breach started. So a lot of different answers there. One thing I did want to come back to, and I had intended to do this earlier, is around the beneficiary choice piece.
Oh,
When the ACO movement started, the policy decision was that the ACO would happen around the beneficiary. Beneficiary didn't even really need to know about it. It was a doctor's choice to participate in an ACO. Beneficiary is assigned based on where they get most of their primary care services. They're not really opting in or out. They're seeing their primary care doctor who is part of an ACO or who isn't. And I think that the picture of like ACO and active choice and beneficiary engagement has really totally evolved over the last 15 years to where we can give beneficiaries tools to make more active choices about their main primary care doctor, for example, and choose more electing to participate in an ACO and better understanding what that means. And so that's an area where we've seen a lot of success with that in ACO Reach. Expect to see more building on that with LEAD, more opportunity for what is called voluntary alignment, the beneficiary electing participation in an ACO, and really look forward to continuing those conversations too. So I hear you saying that perhaps what would be helpful also is like some sort of decision tree tool. So I'm going to take that back around the different models that are available from a practice perspective. It's a good idea.
yeah,
I mean, maybe you weren't saying that, but I'm hearing that.
decision tree might be a kind of an answer, but what we are hearing is that, gosh, all these great things going on, tweaks here, major changes here and there. Some of them sound maybe more appropriate for rural. Some may be for different sorts of practices, specialties, primary care, what have you. So It all sounds favorable, like it's all kind of the ship is moving in the right direction, but knowing where and how to sign on might be helpful. Last word for the two of you. So just in a sentence or two, Jake, um, your outlook for ACOs 5 to 10 years from now is what? Where will we have landed 5 to 10 years from now, do you think, after the current iteration of models and the subsequent adjustments of those? Is our healthcare system going to be significantly affected or adapted accordingly, do you think? Mara, similar question after Jake.
think it's a fascinating question because
Yeah.
thinking about 10 years ago, where we were and the rapid evolution of both costs and then also the rapid evolution of technology in the last decade.
Mhm.
And if we can use the last 10 years and of course, past performance doesn't predict future results, I think that we are in the very beginning of a sea change with regard to our technology-enabled care. And I think that the future of our ACO program is necessarily going to be incorporating technology-enabled care in ways that it's going to be really tough for us to predict at the moment. How and where AI is going to be incorporated in clinical decision making and actually making care better, what care is going to happen first with me as a primary care doc, when are patients going to be chatting with an AI, a chatbot first, what that we're just at the cusp of some really important technological innovation.
Right.
So if I was at the beginning of the say the advent of the internet and trying to predict like the what is going to look like in 10 years, I think I'd have a really hard time. But I think the underlying truth of the matter is we both sides of the Medicare program are incredibly important for each other in terms of their ongoing stability and mutual learning. And so I think that will persist even in a decade. Now, how we're going to be interacting and using what new tools and devices is a fascinating set of questions. There's so much modernization that's happening in the Medicare program. But one thing I think is also going to be happening is I think our underlying claims processing system has been stuck in the, I will say, COBOL past and there's been tremendous interest in HIMSS this week and previously for some of that technological innovation. But we're seeing a sort of at the very core modernization of CMS's claims processing in ways that are
Yeah.
first in a half century, as opposed to first in a decade. So I think there's a depth of commitment to transformation. I think it's really going to be fun and exciting and hard to predict the future.
Well, Jake, I hope you're still doing this 5 or 10 years from now, because if you are, we'll land in a good place. Mara, last word.
Yeah, I agree with that. I think it's rapidly evolving. I'm really optimistic about the future of accountable care because it's what people want, right? Like nobody wants to go to the doctor and have tests done over and over again and have their specialist not talk to their primary. And like my parents are fee-for-service Medicare beneficiaries. And, like I picked my dad up at the hospital. I had a stack of paper like this thick. And I was just thinking to myself, like, what am I supposed to do with that? I don't want that. I want a care
Yeah.
coordinator. Help me. So for that reason, because it is what people want and it is better, it is a better experience, it's better health outcomes, it's lower cost. It's like the only area in Medicare where we see costs coming down. Now we can argue if it's coming down enough, but it's the only place where it's coming down.
Right.
I'm very optimistic for the future, and I think I agree, technology will be a game changer in ways we can't even appreciate, but it does feel like that element is getting better, exponentially better every 2 weeks, it seems. So we're looking forward to all of that and just really thankful to the summit organizers for having me today. We love any opportunity to talk about accountable care. So thanks so
Yeah.
much.
Well, I will say what's really exciting here is that CMMI, and you've been pushed to do this, and you're building on earlier, it's building on earlier work, is trying out a bunch of cool, innovative models at the same time that AI is taking off exponentially. So these models can benefit from the massive data processing and pattern recognition and all that stuff that AI does, the AI or technology enabled things to which you referred, Jake, on top of a lot of innovative modeling going out there. So that seems like it could be an inflection point. So I, for one, am encouraged, much more than I might have been 4 or 5 hours ago. And so, Mara, thank you very much. Jake, thank you so much. And of course, we thank Farzad as well for his input. This has been a great session, a real nice cap off.